I'm going to explain how to do the new emergency room interim insulin pump process that is going to go live on Monday, July 15th, I think. Okay, and I'm going to send out the SBAR today, which is Friday. And so basically, I'm going to walk through the SBAR with you and go back and forth between the SBAR and what you're doing in documentation and the pieces of the packet, okay? So the SBAR, the situation is currently EGH policy states that we remove all insulin pumps. However, we are having some patients refuse to remove them. And so we're in the process of finalizing a beacon-wide insulin pump policies, but we need an interim process. So background, the pump does have to be identified that the patient presents to ER with it. And that the patient must be assessed for competency to manage the pump for their emergency room stay. So there will be this prepared video that's going to be on Workplace and a picture guide that you're going to be using, which I'll reference and show you in a minute. So the workflow, all patients presenting to emergency room wearing an insulin pump must have it documented in the home medication part of Cerner that the pump exists. Not a lot of details, just that it's there. And Dara has worked with me and the pharmacy techs that work in ED. They will be doing this. I need to show you how to do it in case the pharmacy tech is not available. So we're going to go into Cerner, into your patient, and you're going to go under orders, just like you're putting their home meds in. And you're going to click on document medication by history. And then you're going to click add. And in the search engine, you're going to just type in insulin pump. And then double click on it. And done. So down here under drug form, we're going to scroll down because it is an injection. And then under the special instructions box, just ask the patient, what kind of insulin do you have in it? Humalog, Novolog, Apidra. So Novolog. And then you're going to document your history to save it. And you're done. Okay? So that's the documentation piece. And like I said, the pharmacy tech should be doing it, but this is if they don't have one available. Then the second question, number 2, is can the patient continue the pump during ED stay? There are some contraindications. If the patient or caregiver if the patient presents to ER with a diagnosis of DKA or HHS, and HHS is hyperosmolar hyperglycemic syndrome. That's a mouthful. All right, number 2 contraindication is if they have impaired cognition or judgment, or if they have a high suicide risk or attempted suicide. And finally, if they're unable to physically manage the pump. So if they have these contraindications, we need to ask them to suspend or remove the pump as appropriate. And you do not have to remove the insertion cannula if it's a pump that has a separate insertion site. If it's an Omnipod, you'll have to just have them take it off. But other pumps will have a separate insertion site. So you just need them to suspend the pump, obtain an order from your ER doc to discontinue the pump, and obtain alternate insulin regimen orders for their ED stay. If the patient has contraindications and refuses to take the pump off, you need to let the ED doc know and contact risk management immediately for what to do from there. If the patient does not have contraindications, they can continue to use the insulin pump during the ED stay. Side note, there is supposed to be a temporary disconnect or a suspend to unhook it if a patient is going to PET scan, MRI, IV pyelogram, or any nuclear scans, but you don't have to remove that separate cannula site. So when they come back, you can reconnect them. And so once they get back from the procedure, you want to promptly reconnect it and restart the insulin. If it's over an hour, they need alternate insulin because it's rapid acting insulin, and especially type 1s can go into rapid DKA. So Routine care, you're going to treat whatever glucose orders your ER docs are ordering, but if the patient has 2 blood glucoses 300 or more in a row, you're going to ask them to administer a correction bolus via their pump, recheck the sugar in 2 hours if they're still there, and then if the blood sugar still stays over 300, you're going to ask them to change out the site and cannula, or if they don't have the supplies, just remove the pump and get alternate insulin. Also, you're going to utilize the hypoglycemic protocol as needed, and if they come in with a continuous glucose monitor, whether it's associated with the pump or not, hospital policy is we treat only to the AccuCheck Inform 2 glucose meters. We can't use the CGM as treating or dosing insulin. It's not FDA approved. If the patient is admitted to the hospital, you need to contact the nursing supervisors and your friendly diabetes educators, and our phone numbers are on the S-bar that I'm sending out. Let us know the presence of the pump so that we will follow up from the inpatient side. And if you're boarding a patient awaiting a bed, you need to contact the nursing supervisor so then they can determine when the S-bar and the process changes from ER to inpatient. If you have any questions, please let us know. I also want to let you know I'm going to have a laminated copy, and your director, Brooke, is going to have a packet and a folder with packets that have the S-bar and this reference guide for insulin pumps. On this side over here, we have all the different kinds of Medtronic pumps. This is a tandem insulin pump. This is an Omnipod, which is tubeless. These are continuous glucose monitors. This is Medtronic, Dexcom, and Freestyle. This down here is a Vigo. It is not an insulin pump. It's an insulin reservoir. So it is fast-acting insulin, but it is not computerized, so it doesn't have the safety mechanisms that a pump actually does, but it does deliver basal insulin. So just kind of a reference, guys, things that you guys might see as people come into your department.